SESICON organizers, Rajiv sir, and Vishal sir, everybody for this opportunity. I'll be speaking on the SCR versus the lower transfer. So if you ask me, is it comparable? I don't think so, because these two are two ends of the spectrum. So LTT I would do definitely in the posterior superior tear, and SCR is done definitely when the anterior and the posterior forceps are intact. So these two are two different spectrums according to me, but there have been some studies on this. We will go through the studies as well. So coming to the SCR, so we have a massive irreparable rotator cuff, which we know by fatty infiltration 3 and 4. We have patties grade 3, all that we know. So now this, along with significant muscle atrophy, shows that it is possibly irreparable. So now, so what we do is in an SCR, so we prepare it. So normally I would additionally add the biceps also to the anterior cable like this, because it gives more thickness, and we got excellent results with this, and we have had this published. So now after this, we pass the sutures, then shuttle in the facial graft and do like this. So this is the SCR, and last most important thing is the side-to-side repair of the remnant infraspinatus to this graft, because the side-to-side pull is very important in the biomechanics. So this works by the spacer effect, the trampoline effect, and the force coupling effect. So now this is a depicted video of one of our cases. You can see the biceps. So you can see it has been tied down in the anterior cable, and then I would bring in the measuring device, and this measuring device tells me how much of graft is required, and then I would prepare the graft like this, the facial lata graft. I would double it or triple it, because I need to get at least 8 millimeters of thickness, and then shuttle in like this with the suture management as you see in the right side of the image. So this is important, that how we tie it down, and most important lastly is the side-to-side impact as well. So now the graft preparation, the patient is normally in a lateral position, because normally we do this in the lateral. And so you can see the simple straightforward all the way to the facial lata, and you have a 10 centimeter incision, and it should be like 3 to 4 centimeters proximal to the GT, and another 7 centimeters below the GT. You measure it like this and take this and do it. So now, indications are irreparable supraspinatus, anterior posterior forceps should be intact, and there should not be any glenohumeral arteries. So in my data, we had excellent results over a period of time, but I had my failures also, and where the patient went in for reverse shoulder as well. So we have excellent results at 1 year. Coming to the LTT. So LTT, for me, because even when you do what I've noticed in our population study, or in the cases which I have done as that. So the posterior forceps could be intact. That means infraspinatus would be intact in an MRI. But the patient's external lag is positive. If the external lag is positive, and if you look at MRI, you can see that infraspinatus could be intact, but there could be significant fatty infiltration because of disuse or whatever. Whenever the external lag is positive, if you do the SCR, because you feel that only the supraspinatus is affected, it will have inferior results. So that is where I would definitely do a LTT whenever there is a massive tear, and even if the infraspinatus is intact, if the external lag is positive, I will do a LTT. Because what is important to the LTT? LTT is you have a direct line of pull to the lower trapezius, and it is in line with the infraspinatus, and it is quite simple to do arthroscopically assisted as well with fantastic results. So we have two techniques of doing it, the inlay as well as the onlay. So the onlay is where you put the graft. The graft is your choice. It could be allograft, it could be peroneus, or even a semity. So here I'm doing an inlay. I'm basically drilling from posterior to anterior, using a flip cutter, and then shuttling in the graft. And once I've done this, my superior GT is completely free. So when the GT is free, so I have enough space on the footprint to pull back and do a partial repair or a biceps augmented repair. So that's what I've done. So if you compare, what is the onlay? Onlay is basically you don't drill like this, you put the graft on top of it. So if you look at it biomechanically, always the onlay is better because of the pull because it helps in the rotation as well as inferiorization. Now coming to the results, Basamal has excellent results with the LTT. You can look at his results, it's wonderful. And again, more results, excellent results with this. Now, coming to the actual, topic, which is basically the SCR versus LTT in the comparison. So we did have many studies on it. So I could, after looking at the literature, our team looked at the literature, we could find only 2 studies, totally 3 studies, in 2 LTT did well. So this is the study, 2025 study, and this is the sample size, LTT 45, SCR 36. Look at the LTT. LTT is much better. If you look at the forward flexion, abduction, external much better. The failure rates of LTT is much lesser than the SCR. So, but in fact, the important takeaway from this paper was that when there is significant fatty infiltration, always do the LTT. Coming to the next one. So this particular paper, again, very recent. So LTT 36, SCR 22. Again, see the comparison. SCR has inferior results. The forward flexion is 145, external rotation lesser. The scores are much lesser. Progression to arthritis is more with the SCR. Retear is more with the SCR. So again, the same outcome. If you have a posterior tear, or even if you have a significant fatty infiltration in infraspinatus, so then LTT is of choice. But interestingly, one more study where the SCR did well, but there was a bias in the study. The bias was that whenever the patient's external lag was positive in this particular study of 2023, they preferentially did the LTT. So that means there is no match. So they preferentially did the LTT when the lag was positive. So here, there is an automatic bias. That means whenever there is a lag positive, they are doing the LTT, otherwise they are doing the SCR. So here you can see that SCR did well in all the other, that is functional outcomes, ranges, elevation, strength, but LTT was better in the acceleration. To summarize this, you can see that, so overall LTT did well, but except for this particular paper which had a bias. So in my opinion, in conclusion, I would say that these are 2 different spectrums. It should not be confused. I would do an SCR only if the anterior posterior force couples are working. It should be a working force couple, just not on the scanning images. And LTT, definitely if there is a massive posterior tear with a significant acceleration lag possible. Thank you so much for this opportunity.